So thank you for being with us. And we know that with the Lord's presence and with the power of the Holy Spirit, we are aiming to bring comfort to those of us who are distressed by this particular situation. So let me first review the goals for the session. We're going to have 4 of them that we'll divide up between the 3 of us. The first is to review the Supreme Court of Canada decision on medically assisted death. Please note, I am using the expression medically assisted death and the acronym MAD because that is what the Supreme Court decision decided upon. The acronym MAID, M-A-I-D, is the acronym coming from the Bill C-14 regulation of the Supreme Court decision. But I want to be very clear, from our faith perspective, this decision is about medically assisted death. It's not about aid in dying. So first, let's review the decision. Second, let's reflect on what do we mean by the expression moral or spiritual distress, and what might be some of the general causes in this particular issue. Third, after I do a review of general causes for moral and spiritual distress, I'm going to turn it over to my clinical colleagues, and we're going to do a reflection on a real live patient experience or experiences brought into a teaching case to identify sources. And then finally, we're going to ask the question of, in what way is this an issue of concern for you, and how might we and the Archdiocese help? I think it's very important for people to be totally aware of the fact that the Supreme Court of Canada decision decriminalized in February of 2015 medically assisted death for competent adults with a grievous medical condition that is irremediable and that causes suffering. The important things I want people to pay attention to here, particularly in relation to the causes of distress, is this decision had nothing to do with terminal illness. It had nothing to do with dying. It, in fact, was breathtaking in its scope about disease, disability, or illness that is grievous and are irremediable, meaning can't be cured by means acceptable to the individual. The Supreme Court declared that nothing would compel physicians to provide assistance in dying. Bill C-14 came along to regulate medical assistance in dying, and in fact attempted to add reasonably foreseeable natural death, but put under study advanced directives which mature minors in psychiatric diagnosis. The issue of an ethical and moral dilemma is one that we need to be clear on. We know an ethical and moral dilemma is when we're unsure about what's right and good. Ethical moral conflict is when we have irreconcilable differences about the right and the good. Ethical moral distress is when we know in conscience the right thing to do, but the system requires participation in the wrong. Moreover, acting against conscience, we know, produces a moral residue negatively affecting moral sensitivity. Interestingly, the literature on moral distress comes from our nursing colleagues. Some general causes of moral and spiritual distress in MAID first come from the Hippocratic tradition itself. The prohibition against killing and the understanding of medical as a healing art has been overturned. There's been a compromise of palliative care's goal to neither prolong nor hasten death, and neither of those is in the religious realm. And third, and most importantly for us here tonight, there's a challenge of the Catholic Christian spiritual and moral teaching on care for the sick, dying, and suffering. So we have rejected the Hippocratic tradition of not giving a drug that is deadly. We actually have rejected medical morality and come to an ethics dominated by an inaccurate understanding of patient autonomy. Doctors don't do everything the patient wants. They do everything that they ought within the goals and philosophy of medicine. But we have had a commercialization and commodification of medicine. And more importantly, for us, we have a belief in a technical fix for all human issues, including suffering. Palliative care and hospice have had a wonderful understanding of the Catholic tradition of a good death, but they have been rooted in neither hastening nor prolonging death, balancing pain and symptom control with participation in the spiritual, emotional, communal issues, focusing on the dying person and their loved ones. And they have understood in that tradition that palliative care is contradictory to and not compatible with medical assisted dying. Catholic teaching is clear from the Catechism. Whatever its motives and means, direct euthanasia consists in putting an end to the lives of the handicapped, sick, or dying persons. It is morally unacceptable. Thus, an act or omission which of itself or by intention causes death in order to eliminate suffering constitutes murder, gravely contrary to the dignity of the human person and to the respect of the living God, his creator. And then finally, rejecting euthanasia and assisted suicide is crucial. Pope Benedict put it this way: euthanasia is a false solution to the drama of suffering, a solution unworthy of man and woman. Indeed, the true response cannot be to put someone to death, however kindly, but rather to witness to love that helps people to face their pain and agony in a human way. So as we move in this reflection, what we in fact now wish to do is to look at a particular case and see, in relation to the actual experience of patients and loved ones, sources of ethical and spiritual distress.
Thank you, Sister Nuala. While this case was developed out of real patient experience, it has been adapted and modified with elements reflecting various patient and provider experiences to protect the identity and privacy of any individual patient. Michael D. is a 55-year-old male with esophageal cancer who was found to have liver and lung metastases at the time of diagnosis. He has been married to Kay for 12 years and has a 19-year-old stepson, Ethan. Michael had radiation treatments followed by 2 rounds of chemotherapy. CT scans after each of these rounds showed disease progression. Despite this, a 3rd course of chemotherapy was initiated. During his 3rd course of chemo, Michael had an esophageal stent inserted for dysphagia and was subsequently admitted to hospital with sepsis. He was considered now to be too sick for any further chemotherapy. While in hospital, he developed new lower back pain. Bone scans showed metastases to the spine, and CT scans showed dramatic progression of metastases in the lungs and liver. He had spoken to his oncology team about requesting medical assistance in dying, MAID, when he felt he no longer had any quality of life. The palliative care team was then consulted, 20 months after Michael's initial diagnosis, for symptoms of decreased energy, constipation, fatigue, weight loss, pain, and persistent nausea. They carefully reviewed his symptoms, and he was started on subcutaneous Maxaran and Ketorolac in addition to his current medications. At this point, Michael was still ambulatory, able to get out of bed with minimal assistance, and enjoyed sitting in a chair at his bedside during the day. Once he was given the prognosis of disease progression and no further treatment, he opted to remain in hospital for end of life. He said he didn't want his wife to wake up one day and find him dead beside her. He became progressively weaker. He was unable to swallow more than a few sips of liquid at a time and became bedbound. His 2 sisters, both devout Catholics, came from away to help him and his wife and stepson through the illness. He maintained relationships with his family, interacted with staff, and was, for the most part, mentally clear and able to make his own decisions. Michael felt that he still found meaning in each day. Michael was a practicing Catholic, and he met several times with the hospital chaplain to discuss MAID and his desire to protect his family from prolonged suffering. Despite his symptoms being well controlled, Michael made a formal request for MAID. At the time of that request, he was much weaker, but the pain was well controlled and other symptoms were well managed. The MAID physicians determined that he met all the criteria and he was deemed an acceptable candidate. They expressed concern that if he were to wait the required 10-day waiting period, he would lose capacity and would no longer be eligible for MAID. They waived the waiting period and offered him MAID the next day. Michael's wife tried to support Michael in his choices throughout the illness, though she had grave reservations about his choice of MAID, especially because he said it was to save her from suffering. His sisters suffered extreme spiritual distress over the death of their brother by maid and felt that they had been robbed of valuable and irreplaceable time with him. Cases like this one are extremely difficult for everyone involved. Seeing a patient we care about do something that we truly believe to be harmful for them is extremely distressing, both as a healthcare professional and as a person who cares for them. I'd like to highlight from my perspective as a physician just a few of the areas of concern or potential causes for moral distress that can be identified in this case. One of the first things that struck me was that there was no involvement of Michael's primary care provider. We as family docs and other primary providers should ideally have long-term insight into our patients' beliefs, values, and long-term and previous decisions within a relationship of trust. As a result, contact with Michael's primary provider could have been a significant source of support and comfort for Michael and his family. In addition, I think that many family doctors would feel deeply saddened if they only learned of a patient's death by maid after the fact, and this could be a source of moral distress for them. I personally would want to know that I had done everything I could to care for them before they chose death. Second, when the lines are blurred as to whether a provider's role is to provide healing or death, I believe that this inevitably and irrevocably erodes the relationship of trust between patient and physician. We all know that the patient-physician relationship is so crucial to good care. And some patients may even choose to suffer alone at home without seeking care, rather than go to a provider or hospital that they are fearful may kill them rather than provide healing. And there are other questions raised in this case too. Was there a goals of care discussion with Michael early on? Did Michael want to continue with aggressive treatments for as long as he did? Did he even want to waive the waiting period? Will waiving the waiting period simply become the norm? And of course, there is also the potential for moral distress that may arise due to interactions between colleagues who have different beliefs and values. I know Monica will be elaborating on this aspect in more detail, so I turn it over to her now. Monica?
Thanks, Alana. I'd like to just highlight some concerns from a nursing perspective, both in this case specifically and in dealing with MAID in general. I've spoken to a few of my colleagues just about how they've reacted to these cases happening on their units. The prolonged focus on aggressive treatment for Michael really impacted the ability for our team to have meaningful discussions with him about his personal, spiritual, and family care needs. Late involvement of the palliative care team meant that Michael had already made up his mind about his MAID decision, and it made it very difficult to get him to focus on other treatments or other care options. Lack of attention to his family needs and the expedited MAID process was a real cause for concern. This wasn't a family-centered care approach, and it didn't allow time to explore the feelings of his family surrounding his decision. Feelings of unease by the assigned nurse to his case, who felt obligated to participate because it was her patient and she didn't know that she could refuse to be involved. Feelings of failure on the part of the staff and of the team because we were unable to help him to the degree that he wanted, and this was the ending that he chose. Some long-term effects, maybe the knowledge of what has happened. You can't unknow what you've seen or what you know, and how do you deal with that and move on in your career? Feelings of overwhelming sadness for the patient, that this was the best option that he felt he had, and feelings of sadness for the family, having to support their loved one's decision, whether they agreed with it or not, and then having to live with this decision long after their loved one was gone. Distress and knowing deep down that this shouldn't be happening and there's nothing you can do to change it. Helplessness and loss of control over not being able to change the process. And finally, the altering of relationships between your colleagues, respect for your others' decisions to participate or not participate, and respect for each other as professionals, even though we may not agree with their decisions, their actions, or their beliefs. Sister Nuala, would you like to summarize for us the points we've heard in this case before we enter into the conversation with our viewers?
Certainly, and thanks very much, Monica. I think it's interesting to see the general concerns that I focused on, and then the specific real-time concerns that occur in a patient experience. And of course, patient experience is the way most of us healthcare professionals learn anything, actually do dovetail. So what I would like to do now, just in a few minutes before we open it for, if there are questions or concerns that people want to raise, I want to try and see if we can summarize, as soon as I get my slides going here. There we go. What I'm calling moral and spiritual distress issues, with key issues from Michael's case that add to the general concerns that we've seen. So first is the issue of silence in the experience of distress. Medical assisted death has become normalized so rapidly in our country and in our province that people are now feeling incapable of expressing concerns, because in fact it has become the norm. It's, what's your problem? And the silence, of course, becomes a source of great distress. It's clear, and in this case, Michael's symptoms were well controlled as he was dying. Medical assisted death is a response to suffering, not pain. Moreover, death is the treatment here, because there is no prescription or medical surgical procedure to eliminate human suffering. The case and our general concern show the limits of safeguards. What we're seeing here is that many Catholics are either not understanding or not accepting the Church's spiritual and moral tradition on euthanasia and assisted suicide. We're also seeing very practically, despite legal wrangling and attempts to do so, there is difficulties in protecting conscience, and there is the possibility, real and future, of discrimination against persons who object on conscience grounds, who are desperately trying to balance non-abandonment of patients with non-complicity. Just a few key teachings and research information before we open this up. I said assisted death is the medicalization of suffering. Well, this is a small set of quotes. In the original major survey published by Linda Emanuel in 2000, the key determinants of interest in euthanasia relate not to physical symptoms, but to psychological distress and care needs. Linda Ganzini, chief researcher for the Supreme Court of Canada on this area, reviewing Oregon, according to family members, the most important reasons for wanting physician-assisted death were wanting to control the circumstances of death and die at home, worries about the loss of dignity and future losses of independence, quality of life, and self-care ability. No physical symptoms at the time of the request were rated higher than a median of 2 out of 5 in importance. Worries about symptoms and experiences in the future were totally compatible with what we heard about Michael's case. The summary of reasons for medical assisted death then are clear. They're issues of human suffering, not pain. Not that pain is not an issue and we need better pain management and research, but the reasons are feelings of loss of dignity, dependence, guilt at being a burden to others, uncertainty regarding the future and care needs, a sense of loss of control, and hopelessness and loss of meaning. Let's be very clear that there are different types of suffering. And while there is a neurocognitive suffering, that is a suffering directly related to physical conditions, most suffering is what we call agent narrative. It's about relationships. It's a total human, emotional, spiritual experience. When we come to Christians understanding the tradition of our response to end-of-life care and suffering, Gethsemane and Jesus has to be before us. The Catholic Health Ministry document published here in Canada puts it this way: while pain and suffering are to be relieved at all cost, when accepted in faith, suffering does have redemptive value. This does not mean that God takes pleasure in human pain and suffering, nor does it mean that Christians are to be passive in accepting suffering and not strive to alleviate or eradicate it at its source. Jesus suffered the temptation of wanting to go around and avoid suffering. And his response to trust in God was to work through suffering, and thereby there is the resurrection and our faith. We can also see that what's happened around us is a loss of a sense of medical morality and conscience. So while Catholic teaching is crucial on the importance of conscience, and conscientious objectors really are trying to balance non-abandonment and non-complicity with wrongdoing, the general secular understanding of conscience, legal and philosophic in our society, is frightening. It sees conscience as a private and religious claim that has no place in the doctor-patient relationship. It sees it as a conflict between the physician's right to conscience and the patient's right to medical-assisted death. And most important, refusal is based on conscience is seen as a selfish abuse of power, and then opens itself to Monica's concern about discrimination for those who conscientiously object. If you think I'm exaggerating, I'm now reading for you two of the harshest judgments out there published in the BMJ in 2006. If people are not prepared to offer legally permitted, efficient and beneficial care to a patient because it conflicts with their values, they should not be doctors. More startling, 2017, professional societies should declare conscientious objection unethical. So we have distress from lots of sources, from changes to medicine and the doctor-patient relationship, to a capitulation to a market model of medicine, a real identity crisis for the profession, which is a major factor in the burnout, which is now a compelling concern across this country and this province. And most importantly, we see that conscience, which is a crucial Catholic concept, in fact, is seen to be a dirty word in the public domain. So what we'd like to do now is see if anyone has comments, concerns, personal experiences of their own that we might begin to gather together. And remember, we're asking this partly to have a sense that we can provide you with a safe space for persons of faith to begin to share the kinds of distress that they are experiencing, but also for a place to gather the concerns and the issues so that we can find out, is there a way that we need as an archdiocese and as a church to support in a different and new way those who are in fact experiencing this distress in all our hospitals. It's interesting that in many places in Canada, they still have Catholic hospitals, and that's not so in our archdiocese. But there's not a single hospital or a palliative care hospice unit anywhere in this province that doesn't have Catholics who are integrally involved in care. So, any comments, any concerns, any issues that are compelling to you that we might either comment on or begin to develop some kind of response for in the long run. Now we're waiting for the technology to kick in with your questions or concerns.
Yeah, so you there's a little question and answer button at the bottom of your screen. Corey's just asking us to remind you how to do that. If you run your cursor over the bottom of your screen, it'll pop up. There's a little folder called Q&A, and you can click on that, and it'll open up into a dialog box that you can ask us a question or give us a comment.
In fact, one comment that I'd be interested in is anything that we just said resonating with you? Are we capturing some? We believe that the issue from our experiences and knowing and working with many people is this is an issue. We responded to it from the committee because we had a number of persons asking us to do this, particularly on the behalf of Catholic doctors and nurses in particular. So while we're waiting for some questions, I think I was thinking as people, my two colleagues were presenting, I am actually becoming very concerned about two issues. One is that ordinary Catholics do not seem to understand why it is that that medically assisted death is in fact something we would consider wrong. The essential, central tenet of our faith is really the Paschal mystery. It's the suffering, death, and resurrection of Jesus Christ. Jesus only gets to resurrection because he goes through suffering, not around it. And you remember, it's been within the last few weeks. Jesus is telling his disciples that he's going to have to suffer. And Peter says, hey, stop that. What are you talking about that, Lord? Don't talk like that. And what does Jesus say to him? Get behind me, Satan. Because he knew that the Son of Man had to suffer. So we don't seek suffering, and we have an obligation to deal with it. But in actual fact, because Jesus accepted, trusted that God would take care of him no matter what, he comes through this. And how could anyone imagine resurrection? Which is what is the result of that. So the concern I have big time is that many Catholics think that medically assisted death is the compassionate and merciful response. The second thing I worry about, and it feeds into something that Monica said, I'm desperately worried that the silencing that has occurred with the rapid normalization means that we, in fact, have all kinds of Catholics who are being discriminated against when they attempt to raise any concern that maybe this is something that's not right, or at least not right for them, and raising questions that are bigger. But I don't know if the two of you, while we're waiting to see if anyone else has concerns.
Just one of the things I was going to comment on, one thing that you just said about that difference of how sometimes it's perceived as the merciful thing. And I was at a conference recently, and one of the speakers, he had sort of collected this definition of mercy that I really felt explained it well. And it was that for him, the mercy is the diving into the chaos of another person's life and providing lifting and healing to the other person, to that person. And, that's why palliative care is the fullness of mercy, because it dives, it provides both aspects of that. It dives into the chaos of people's lives, but it lifts and heals. And, euthanasia and assisted death don't provide any of that lifting and healing. It's
Right.
just the diving in. That was interesting.
Right, so we do have one concern that we've got up in front of us. You should be seeing it, or I don't know if you can see it as well. So it's a question, I'll ask it, and then you two actually will probably, when I don't know the answer, I've got two friends who can. So here's a concern, asking how many advances have been made in sending someone home to die, and talking about an experience with their mother 25 years ago, and they didn't get support. They didn't know what this was going to be like, and that it was a horrible experience for them to be trying to care for her, but with no help, no assistance. And the person describing the fact that because that was so difficult, they could see that they would want to just say, get it over with. Let's end mother's life because of that. So the issue of what kind of support is one that maybe I'll turn to. Let's turn to Alana first, because Monica first, because she's in palliative care. Mm-hmm. But this is a historical problem. Mm-hmm. Canada legalized medical assisted death before it delivered on its 15-20-year series of promises on having access for all Canadians in rural and urban areas, in communities, in homes, to optimum hospice palliative care. So this is this crucial issue, and thank you for raising it.
Mm-hmm. So we have a palliative care community team, certainly here within the city of Halifax, and I believe throughout most of the province, palliative care is available rurally. We work with continuing care, and we work with VON to provide support to families. They provide physical care, they provide pain and symptom management. Our doctors and nurse teams will go into the patient's homes and assist in every way that we can. We've made many advances in pain control over the last few years, and there's really not a whole lot that can't be done at home that a patient would have to go to hospital for. Families are taught to give injections, they're supported every step of the way. So unfortunately, 25 years ago, maybe that was not the case, but certainly in the past, I'd say I've been a palliative care nurse now for 18 years, and certainly in the last 18 years, we've made a lot of progress, especially with our association with the community teams.
Yeah, I think there are still probably some gaps in certain places, places because of geography, and we try to accommodate those in other ways. And there's just some in terms of just resources, in terms of having the palliative care nurses, or that have positions in those areas. And there are certainly things that I think we're all trying to work hard in our own communities. So to try to fix. I think that question also asked the meaning of MAID, and it's medical assistance in dying is the official acronym, I think. And
medical assistance in dying is the title of Bill C-14, which regulated the Supreme Court of Canada decision. So that's what they call it.
But as we've said many times, that's what palliative care, assistance in dying is what palliative care and family physicians and pastoral care workers and everybody has done forever. It's certainly not.
Right. I think the other thing that Monica reminds me, and there's one or two comments up here, that the issue of pain control is a hugely important issue. It's important from both the side of the caregivers and of the patient and their loved ones. There are huge misunderstandings out there. You two now confirm this for me. There are huge misunderstandings out there about pain control, and Catholics have to offer it up. And clearly the obligation of those who are caring for those who are sick, suffering, and dying is to provide optimal physical pain and other physical symptoms. It's not just pain. We have an obligation and duty to do that. But the issue is that sometimes people have a misunderstanding about what that is, or a misunderstanding when in fact pain control has the person beginning to be less conscious and less interactive. All kinds of misunderstandings. That hasn't helped anything. And then on the other side, the competence that is necessary for doctors and nurses in adequate optimum pain control in the 21st century isn't always there, though we've made great strides with medical education. There's another question there that how can a non-medical Catholic help support medical physicians? What do you think, Alana?
In their worries and in their work? You know what, I think just talking to, if you know any Catholic healthcare professionals, just being open to them, that you share their concerns, asking them if there's anything they need support or help with. I think that just knowing that you're out there wanting healthcare professionals who share your values is important. And so I think letting people know that, letting the governments know that, letting the health authority know that, I think is all really important. So that when they're making these decisions about, how to proceed with these kind of policies, they'll take us into account. They'll know that that we are valued members of the healthcare teams.
And there was, I don't know if it's the next comment there, but there was one that flashed before about, does this issue affect volunteers in hospitals?
Yeah,
well,
sure.
One of the large groups that have been affected are all of the folk who do parish hospital visiting and some form of pastoral care of the sick and dying, particularly in hospitals. But remember this, medical assistance in death actually doesn't and isn't going to be most commonly performed in hospital. This can be performed anywhere, in the home, in the community, in long-term care facilities, and residential treatment facilities. So there's a large arena for distress with far less of the competence and control mechanisms that actually occur in hospitals. But the number of people who try to come in and support an individual, particularly with pastoral care concerns, when the person is considering the issue of medical assisted death, this is a huge area of concern. And it's not just for our chaplains. It is definitely for our chaplains, particularly our priest chaplains and then lay chaplains, but it's for all of those. So the person who's asking, is this an issue for volunteers? It's a crucial issue. And I guess I would say sometimes the folks who either don't have a dying loved one now or a seriously ill loved one, or who don't visit hospital, don't understand how much of this is going on. And is that right?
Yeah, that's true. Yep, that's true. I'd like to address the question there. Can you say again the difference between comfort, palliative hospice care, and medically assisted dying? Palliative and hospice care, one of our focuses is that we don't either hasten or prolong death. We assist the patient to live to the best of their ability for whatever time they have left. And I think that's the huge difference, is that we're not focused on an end point. We're focused on the living until the patient gets to that point. And the main focus of medically assisted death is to get the patient to that point as quickly as possible, it seems, these days. A few conversations have had include discussion from meds to comfort. A lot of times we do need to use medications for patients for comfort if the pain or other symptoms are out of control, with the knowledge that sometimes the medications that we use makes the patient less responsive and less able to participate. But again, it's about the intention of the medication used, the reason why you're using it. You're using it to control their symptoms. You're not using it to hasten their death. There's a big difference there, but the lines are very blurry sometimes.
There's also a comment by one of you that says not only Catholics, but also other Christians, Jews, Muslims, and people of conscience. And certainly there's been lots of support from other faiths and those of no faith whatsoever. And the same person says, in your case, the palliative care team should have been involved from the time of initial presentation with advanced metastases. And we couldn't agree with you more. Absolutely.
There's one interesting, I think this is an important comment about it being at one level for all persons of faith. I actually did participate on behalf of the Canadian Conference of Catholic Bishops with Bishop Terry Prendergast at an activity on Parliament Hill immediately after the Supreme Court decision. And we had all of the Abrahamic traditions. So we had the Judaic tradition, the Islamic tradition, and the Catholic and evangelical Christian positions present. We can come together there on the issue of this being, at the spiritual level, a contradiction to the recognition of God's dominion over life and the gift of life and the sanctity of human life. The issue of suffering and medical assisted death as a relief of suffering has a very particular take in the Christian tradition. That is not shared by either our Muslim or our Judaic colleagues. So but the point's well taken that there are many, many persons of all kinds of faiths who have a particular issue with this.
And speaking of that press conference, I've used it in another presentation because it's such a powerful witness of some of the good that is coming out of some of these horrible decisions is uniting all people of goodwill kind of in this issue.
There's a question there, and I actually meant to look at the statistics before I came, and I didn't, as to how many deaths have occurred in Nova Scotia. Do either of you remember hearing any numbers?
I haven't heard any recently.
I know the Department of Health only releases them about once a month or less frequently, so that.
Right. So this has been legal since about August of last year, right? So it's over a year and 2 months now. But I don't know the number. I should check that. So sorry about that. If anybody out there knows the number, then share it with us. Yeah.
I can Google it quickly.
How about the question, would you agree that the case presented highlights the importance of how the patient dies is really a decision involving the family, GP, and all others involved in the case, and that the discussion has to take place much before the final stage of illness? Absolutely. The sooner, it all comes down to advanced care planning, and the sooner you can have discussions with your patient and their families about how they want things to proceed, what options are available, and what kind of supports are there to them, I think.
So that question is asked by a classmate of mine. So thank you, doctor. and of course we agree with you. That's absolutely right. And it was a main point that Alana tried to make in all of this. If we could look just for a sec at this question about do unions, professional associations, and human resources Department of Nova Scotia Health acknowledge the reality of moral distress and then go on about that? Well, that is an interesting question, because it is my belief that it's not being understood directly as moral distress. So if you look at, for those the docs in the audience, or those who can find a doc and get his copy of the Doctors Nova Scotia Bulletin, there is in that the last bulletin a survey about physician burnout in Nova Scotia. In addition, the Canadian Medical Association has a major initiative now, and I'm just trying to write a response to them about physician burnout. And I'm not trying to be, because this is such a serious issue, facetious, but I really want to say to the CMA, I told you so. I mean, I have since before this Supreme Court decision, tried to get the Canadian Medical Association to understand that what was happening, this is the point I was trying to make about medical history. There's no new technology. This is not cloning where we got to figure out how to do it. And Hippocrates never had to ask that question. It's throughout the 2,400-year tradition of Hippocratic medicine, at any time, docs could, in fact, end the life of patients at their request and without their request. So that there's something profoundly rooted in what I'm considering the inherent morality of medicine that has been lost. Of course, that means that, in fact, it's going to cause deep moral distress. So the surveys about burnout that are going on talk about increased expectation, workload, all these. But some of the increased expectation is precisely that doctors and technology can, in fact, fix everything, including human suffering. And so I would say that individual who asked that question, one of the things in terms of advocacy that I know a number of us are trying to do is to get, and I wasn't thinking of the Department of Health, but professional groups to understand that the burnout question has a number of factors, but this legislation is not a small part.
Yeah, and I think that's one of the things that Doctors Nova Scotia should be commended for, because they took the initiative to have this survey done. And one of the, as Sister Noel pointed out, some of the other factors, one of them was the fact that your values correlate to your organizational or the environment that which you work, that your values correspond to theirs. And when they don't, that is a factor in burnout. So this certainly would be topical for them. In the case presented, it was 20, so it was actually 20 months. So
even worse.
It was 20 months before the palliative care team was consulted. Why would it take so long for that to happen? Whose responsibility is it to involve palliative care?
It's up to the treating team to involve the palliative care team, and lots of times it goes both ways. The treating team will suggest it, and the patient will say, no way, I'm not ready, because I know what those people do. Or the physician, the physician or the treating team themselves have a hard time saying, I don't think there's anything else we can do. We need to bring in palliative care. So sometimes it's both sides.
Right.
Yeah.
Let me pick up on the expression that Monica used, because I've said, partly facetiously, partly dead serious, to medical students and residents when I teach. If I ever hear that any of you use the expression, there's nothing more we can do, we'll refer you to palliative care, I will come back and haunt them if we're allowed to haunt. This is so wrong, and it's part of the misunderstanding about hospice and palliative care, even for Catholics. Where, I mean, and I have a great quote from Pope Francis on palliative care and how compatible it is with the Christian understanding, Catholic understanding of a good death. That's the three traditional goals of medicine have been to cure, and that happens rarely, even today. The second is to improve symptoms, quality of life. That's the commonest thing that medicine does. That's still today. And the third is to recognize when disease has overmastered the patient, that's the Hippocratic language, and to support the person with comfort and care in their dying. Those have been the traditional goals of medicine. But in modern times, we've become so used to, you drop down dead and we're going to get you back up again. We'll resuscitate you. And if we didn't resuscitate you, if Alana couldn't do it, it's because, she's just not technically good enough. Yeah. So the issue is we've become so confused about some of these issues that we haven't realized that, in fact, dealing with support and care, proper care and support for those who are dying and accompanying them and their loved ones is an essential goal of medicine.
And that's true compassion.
And that's compassion.
Walk with them.
That's right.
Someone graciously looked up for us the answer to how many there have been. I presume this is in Nova Scotia, of course. 67 requests and 31 received.
And that actually points out something that that I think is important. We know this from the Oregon experience. We knew this early on. And that is this fact, that once medical assistance in dying, euthanasia and or medical assisted suicide, are legalized, many people who are interested in it will move to making a request, but where in most jurisdictions, for example, in the United States, what's been legalized is medical assisted suicide, but that's not what's happening in Canada. In Canada, it's euthanasia. That is the difference. With medically assisted suicide, the patient requests, the doctor does the criteria, provides a prescription to the patient that then they take whenever they want. Doctor is not present at the time that the patient takes it. Euthanasia is different. Euthanasia is the patient makes the request, and the doctor is the actual physical agent, not just of the prescription, but of basically an injection to cause the death. Obviously, the doctor has to be present at that time. In the United States, most legislation, virtually all, is medically assisted suicide. And there what we see is people who are worried, they want to kind of ace in the hole if things get too bad, request the prescription, but don't take it. So you see you've got more requests than you actually have procedures performed. Does that help us? It's just something for us to be aware of and to think about. And this is interesting about the Canadian experience. When this was on the go, before the discussions and conversations, before the Supreme Court decision, many people thought this was going to be about, many doctors I know, thought it was going to be about medically assisted suicide, which makes many of my colleagues in medicine think they're a little bit removed, right? They'll provide the drug, but you're the one who's you're going to be the agent of your own death. Well, in fact, for a lot of reasons, including our opioid crisis, our fentanyl overdose crisis, provincial pharmacies are not providing the packet of medication that people can then take and keep at home because they don't want these drugs available. So what's actually happened in effect is doctors are now required to be the agents directly almost always in this country. Interesting difference. And morally, I think, contributing to some of the moral distress.
And a clarification, the stats that we gave out apparently was as of April 2017 for Nova Scotia. And there's another comment about the wonderful palliative care that many people have had in Halifax. And I'd say that's definitely true. When people really, they were support to to a mom and wife that they knew. And I think that's true. And that's why we are all such great advocates of palliative care as being the true way forward in this.
Right, I think that what we're going to have to do with the time that we've got is to begin to bring this to a close. We thank those of you who gave us some comments. We think that this is just the beginning of a conversation. We're not sure how much of an issue, particularly for Catholic health providers and pastoral care workers in hospitals, long-term care facilities, and hospices and the like. But we really do want you to begin to think about the issue and let us know, let the Ministry of Care and Companionship Committee know what we need to say and do to help provide supports for you. What are the issues that are compelling? We're very aware that, first of all, we need to give a big thanks to Aurea Sadie and Christine Salterio and the folks in the communications department here at the Archdiocese. I mean, they have been, we couldn't do this without them. They're fantastic. But we do this work and request time for this kind of thing in their busy schedules. So we're aware that by the time we decided that we had heard requests that we think needed us to do this, tried to put something together we thought was meaningful, there wasn't much notice time, and there wasn't time for us to make the kind of contacts directly with doctors and nurses that we know are working throughout the Archdiocese. So that means what we want you to think about, and Aurea will be sending you a little thank you, not with an evaluation, but with 3 questions. Was this helpful? Are there issues out there that are of concern to you, and what are they? And should we try to continue to develop resources, either more specific theme-related webinars, and how might we do that, advertising them far earlier, right, than this one? Is there a need for some kind of perhaps 2018 gathering of the Catholic healthcare professional faithful as part of the Archdiocese movement towards evangelization and information and support? We don't know what you need, but if it is a need, you tell us that, and you tell us what the themes might be and what format might be helpful, and we can certainly bring that, Monica and I will bring it to the committee, and then the committee will bring it to the Archbishop, who is totally supportive of the work that we're doing here. You have any comments that add to that, or?
No, I think that's great.
That's great.
So thank you for participating. We do hope that though we compacted a lot of stuff, we were trying to take an issue that is huge, and the more we plumbed it, the more difficult and complex it was. To begin to name it, to beginning to break the silence even within the faith community about talking about it, about talking about the pressures, talking about the difficulties, the sadness sometimes, the sense of failure, and not providing support the way we ought to people or the way that they need. So thank you for participating. Please tell us, was this helpful? Is there more that we need doing? And what are the themes that you would like us to participate in? And if we do another thing, you're going to be nagged and snagged to name your friends and family and colleagues who are doctors, nurses, respiratory therapists, hospital administrators, chaplains,
Pharmacists,
everyone.
everyone in the family of the faith. Thanks.
God bless.
good night.